what protocol is open and what protocol can children be on. So we thought for hydrocephalus, we could do something similar and try to have every child on some protocol. So we wanted to collect prospective data, standardize care where appropriate, and conduct collaborative research. And we started with 4 sites, and it's gradually grown. And you can see the participating sites now. There's 14, 3 in Canada, and 11 in the US at present. Then we have data management at Data Coordinating Center here in Salt Lake City. So the strategy was to have a registry or a core data project, and this has been approved without patient consent by all the IRBs. So it allows us to capture every child that comes through these centers and characterize the population. This is every child that's getting treated for hydrocephalus. Allows us to identify variation in practice, and it allows us to generate study ideas and study questions. And so there are a number of different study lines that you can see here, and I'm not going to go through all of them in detail, but this is the core data project, or the registry, that's kind of the backbone of the network. And this has really turned out to be a gold mine. So there's now a very large number of cases. And whatever we're going to study, it always provides us with a first look at the study question. And we can do an initial analysis of whatever the study question is and usually publish something just from the existing data that's in the registry. Because we have multiple centers in it, it shows variation from one center to one center. And this is an example just showing the proportion of hydrocephalus patients at each of these centers that is due to the different etiologies. So if you look at this center, this is the proportion of hydrocephalus that's due to myelomeningocele, and that's very different than this center. And that becomes really important when we're doing analysis, because these are prognostic factors. But if you don't know about this kind of variation, you can't adjust for it. It allows us to look at trends over time now that we've been doing this for more than 10 years. And this is an analysis that was done by Mandeep Tamber, who's in the network in Vancouver. And he's looked at the use of shunt as first treatment, and each of these lines is a center. And not surprisingly, we see that shunt as first treatment has gone down over the period of observation here. And that's further borne out here in this relatively short time window. We saw the proportion of first procedures being shunt dropping, and the proportion of ETVs under 2 going up dramatically. So clearly seems to be the effect of increasing use of ETV with CPC. So the other advantage of the registry is it gives us a huge number. So this is from the spring of this calendar year. This is the number of procedures and the number of patients. And that allows very powerful analyses and allows you to adjust for multiple prognostic factors, as J. Reva Cameron did quite some time ago now, looking at first shunt failure in 1,000 children and finding that age under 6 was an important prognostic factor. Interestingly, cardiac comorbidity was a prognostic factor. Valve had no impact on survival in that analysis. And the other thing that's been really important for us is this database allows us to very accurately predict accrual when we're planning a prospective trial and calculate sample size. So many different studies going on, and just a few highlights. Jay Wellens at Vanderbilt has been interested in the study of intraventricular hemorrhage, and this was a very early study looking at subgaleal shunt versus reservoir, and it seemed there was an advantage to reservoir, but then we found that the biggest predictor in the whole thing was center. There was a huge amount of center variation, and children were being treated for different indications. So when we followed a standard protocol, so we were making the decisions the same way about when to treat these children and when to convert them to a shunt. And then the difference between the 2 procedures completely went away. So I think you can see this is an advantage of having multiple centers participating and allowing you to identify these kind of things that are prognostic and adjust for them. Bill Whitehead, who's in Houston, was looking at factors for shunt failure, and found that it appeared like the anterior entry site had an advantage over posterior entry site. But there were mixed results around the world, and so that led to a randomized trial, which we're just about done. Patients were randomized to anterior versus posterior entry site. The data is complete, the analysis is almost complete, and I asked Bill if I could present results here, but he had already committed to presenting results in a few weeks at the pediatric section meeting. Unfortunately, because it's virtual this year, anyone can attend. Here's how you would register. It was intended that we would be hosting the meeting in Salt Lake, but as I say, it's going to be virtual. So that's December 2nd to the 4th, and Bill will present the primary results of the trial at that meeting. So please join that if you can. No doubt we're studying ETV CPC, and many of our investigators have been to Uganda and worked with Ben and learned the technique and taught others. And so there have been a number of studies. The first one basically just asked, can we follow a standard protocol with this procedure? So with common entry criteria that we all use, with common outcome criteria that we all use, and with a standard surgical technique. And so we did this for a while, and Abaya wrote this up and presented it on one of the I can't remember the name of the, Clash of the Titans sessions. But it was children with first-time hydrocephalus under 24 months of age and ventricles enlarged above an FOR of 45. And we had standard outcome criteria that we followed and standard surgical technique. And more than 3/4 of the patients had at least 90% CPC performed. They were young, most of them were under 6 months, and most of them had an ETV success score of less than 50%. And this was the overall curve for the ETV CPC that we obtained from that trial. Of course, it was age dependent. This was another analysis that J. Riva Cameron wrote up looking at risk factors for failure, and clearly there was an age effect with, this is the curve for children under a month of age. And as you can see, there's a dose response here, impact of age. And this includes all comers, including all etiologies. And that turned out to be very important as well. So this is premature intraventricular hemorrhage here, which has a very poor success rate in our hands. And all the other etiologies were very similar, a little below, or approximately a 50% success rate in this time window, which is out to about a year, year and a half. So that's led to a randomized trial, or sorry, before that, Mandeep Tamber and Rob Naftel at Vanderbilt have just published a paper this month, I think it is, in JNS Pediatrics, where they asked 400 patients and families what was important to them. And the most important thing was cognitive function. They would like to be shunt-free as long as it didn't hurt their cognitive function. So that led to the study question that we're just launching. And this is a randomized trial, and it says, does initial treatment with ETV CPC result in worse cognitive function compared to shunt? And note, this is initial treatment. So we're recognizing that patients will cross over because some of these will fail, but is it harmful to start with ETV CPC? So this trial has just started. We've literally randomized about 3 or 4 patients, and the primary outcome is going to be developmental outcome at a year. So we've got a long way to go, but we're getting started on that trial. Many other study lines. Dave Limbrick is looking at biomarkers in the CSF and seems to be in association with Bailey 3 motor outcome with NCAM1, but there's a lot more detail to that he's currently writing. And J. Riva Cameron has looked at ventricle size and found that there was no association in the pre-post change in ventricle size with a number of developmental outcomes, and no association between ventricle size and GPA or HOQ. There were some associations with delayed verbal learning and with visual spatial judgment, but the vast majority of the developmental testing was not associated with ventricle size. This is all children who started treatment over 5 years of age. So of course, the babies aren't in there, which is going to be very important. Lastly, if you haven't been involved in this in different parts of the world, the quality improvement movement is certainly huge in North America, and I suspect in many parts of Europe, where we standardize care, reduce variation, and see if it improves outcome. So we've done that in the infection world, and we have found that it certainly can have an impact. We follow a standard protocol, measure compliance, measure other factors, and go back and revise the protocol. So it's an iterative process. And this is just one example of a couple protocols that we've used in the network. Last comment, so this is about the gap between what we know and what we do, and it's great to publish all these studies, but if people don't implement the results, then we're not going to help the overall community that much. So we've created a second sort of companion network of 29 sites that really is the implementation arm of HCRN. So we feel that we're doing the investigative work. When we find something that works, then it's being spread out through this expanded network. And there are 29 sites that are interested in doing that. So we've just got that going in the last year. And we've got about 800 cases in that new database. And so the idea is we'll get baseline data on what they're doing. We're starting with infection because it's simple. And then we will get but then we will come back to them and say, okay, our data says these are the things that work. Ask them to implement those, record compliance, and see if we're making an impact on a broader basis. So I'm going to stop there. I've got at the time limit and see if there's any questions. Thank you very much.
Thank you, John. That was a great overview of the fantastic work you guys are doing. We haven't got any questions coming through in the Q&A at this point. I'll keep an eye out for some. With the clinical trials that you're running, they're run within the network, is my understanding from what you just said, but then you push the work out. Is that correct? And
right. So we're doing these clinical trials, and then this new network is more of implementing findings, and it's not just our findings; it's anything in the literature that seems to be effective. So in the infection example, we've used a couple of different protocols to try and reduce infection. And so in the first year of this new network, we've just recorded what sites are doing. And the idea is that we will collect data on what they're doing and the risk factors for infection. But the idea is to keep the data collection much, much smaller than we're doing in the HCRN network, just enough to risk adjust and provide them with feedback. So we will then give them back their infection rate compared to the network. Depending on the numbers of cases, it can be site or even surgeon specific. And then once we have baseline data, we'll say, okay, here's what we just did another analysis of 5,000 cases in our network. So now we can go and say, okay, based on that analysis and based on things like Connor's trial on antibiotic impregnated catheters, we can say, here's what we think is the current best evidence for preventing infection. Keep going, and then we'll monitor whether they incorporate those steps or not, and see what it does to their infection rate. And so it's an iterative process over time. But exactly, we're doing the detailed investigative work, and then implementing protocols in this other broader network.
Got a very quick question from Federico De Rocco. A quick question: is 5 years follow-up enough to evaluate the effect on the physiology of the cauterization of choroid plexus, or is the CPC effect transitory and does the choroid plexus regrow?
Well, I don't know. So we have Ben's data from Uganda that went out to a year follow-up, and we set our primary outcome at a year. We are funded for 7 years total. So all of the children in the trial will have follow-up at 3 years of age, and depending on the rate of accrual, at least half of them will have follow-up out to 5 years of age. Is that long enough? I don't know. You always have the option of applying for additional funding to continue follow-up with something like this, but that's the current plan.
Yeah, we re-endoscoped a number of Hugh Griffiths' CPC patients and not seen any regrowth of the choroid plexus. I think the bigger question is the longer-term effect of lowering your CSF production rate, I guess.
Right. I think that'd be very long-term to find that out.
Yeah. John, thank you very much. Fantastic talk.